So good afternoon, everyone. The conventional ILM pill does not give predictable good anatomical outcomes in large macular holes, such as demonstrated by this failed macular hole. These 6 papers, which are a few of several papers published early part of this year, with a series by Cassini et al. Having the highest number of eyes, all record impressive anatomical outcomes with good closure rates. Therefore, the ILM flap technique appears to be superior to the ILM pill technique in this category of difficult cases with improved anatomical outcome and visual recovery. But does it result in reconstitution of the outer retina, such as seen in this post-operative OCT of a large-sized macular hole with excellent ISOS and ELM presence? So we considered this question in a series of large-sized macular holes as exemplified by these 1400, 600, 1100, and 1200 microns macular holes. We retrospectively reviewed pre-op and post-op SD OCT images of 14 consecutive eyes of 14 patients who had an ILM flap technique for macular holes with base diameter larger than 400 microns. The procedure was a standard 23-gauge vitrectomy with dual blue-assisted membrane peel. Initial cases were done with ILM folded and tucked into the macular hole. And in later cases, our technique changed to just an ILM bridging flap left to lie over the macular hole. The average age of these patients was 62 years, and the average symptom duration was 16 months. Average follow-up period was close to 1 year. Furthermore, we categorized the macular holes into A, B, C, A being less than 500 microns, B 500 to 1,000 microns, and C larger than 1,000 microns. There was 1 eye in category A, 7 in category B, and 6 eyes in category C. The tamponade agent was also reviewed, and as you can see, air alone was sufficient in this 1,400 micron size hole, as SF6 was also used in a 1,500 micron. We did not apply strict face-down positioning. So what were the results like? 100% hole closure rate, visual acuity improved, and at least 2 patients had a 4-line gain in improvement. The 2 patients who had a decrease in their vision was actually due to cataract, and they had excellent hole closure rates, and we expect improvement in their vision following cataract surgery. Now, to answer the question as to the outer retinal reconstruction, we consider the ISOS and ELM presence or absence on post-op SD-OCT. So for us, the outer retina was seen when we looked at the outer retina considering the ISOS and ELM, and it was continuous. If it was present, there had to be a presence of the ISOS and ELM under the subfoveal space. And if this subfoveal ILM was continuous with the parafoveal, it was said to be continuous. It was broken, it was said to be broken. If there was no ISOS under the subfoveal space, it was said to be absent. As we can see in this slide, showing SD-OCT, and we can see the flap, and there we can see an absence of ISOS. It's also absent in this 700 micron hole. Is absent also in this 1,400 micron hole. We can see closure, but there is no ISOS. And we can see that in this case of a 600 micron hole, there's good closure, good ISOS. We say this is present and continuous. Another present continuous with the flap on top, present continuous. And we can see in this case it's present and broken. So to summarize, the outer retina was present in 6 eyes. The outer retina was present in 6 eyes, and it was absent in 6 eyes and present in 8 eyes, of which 4 were continuous and 4 showed features of being broken. The average macular hole base diameter for all 14 macular holes was about 900 microns. For all the patients who had an absent hole, it was about 1,200 microns. And then for those patients who had a broken hole, who had a broken ISOS, it was about 800 microns. For those patients with present and continuous, which is what we really wanted, was about 600 microns. And so you can see that there's a correlation between the size of the macular hole and the presence of outer retinas. And this was confirmed by the statistical analysis we did. We could show that most of the absents were at the bottom, showing the larger holes. So to summarize, yes, indeed, the outer retina can be reconsidered in some large macular holes with the flap technique. Preoperative macular hole size does correlate with post-operative outer retinal presence. In our hands and in our experience, it is safe to say that macular holes less than 800 microns indeed could have a complete or partial reconstitution of the ISOS. If the macular hole size was greater than 1,000, there may be no reconstitution at all. Now, this is important given the fact that if we can predict and be able to say, yes, there will be an outer retinal reconstruction, then we can apply the macular hole with the flap, and we'll be sure there will be a reconstruction. But if the macular hole size is much larger than 100, we may not have a reconstruction, and this category of eyes may be eyes in which we may have to think of other techniques, such as the autologous retinal transplant. In these, the sample size is small, and we need larger samples to be able to make conclusive results, and we did not compare the TOC technique as against the bridging flap. Thank you very much for your time.
Thank you. Thank you. Any questions or comments from the table?
Okay. So I was speaking with Gyasi about how did you measure the whole diameter? You're measuring the inner diameter or the largest diameter?
Actually, for this study, we used the base diameter.
You used the base diameter?
The base diameter, yes, was what we used. And so what we do is we measure the base diameter with looking at the vertical and the horizontal.
Because usually what we do is we find the largest section where the hole is, and then we measure the smallest diameter, right? I mean, there are different measures, but I don't know, why did you take the basal diameter?
Well, we wanted to be very clear about we wanted it to be reproducible. So for all the eyes, because in some cases the configuration of the macular hole is different. So we just wanted to kind of standardize for the purpose of this study so that we had a uniform way of measuring for all the eyes.
Yeah. I guess that one more conclusion is that if the outer retina cannot be reconstitution, there is also a correlation with visual acuity and functional results,
Absolutely.
Right?
Yeah.
So above 800 microns, the functional results are worse.
Exactly. In our series, if it was more than 1,000, definitely the likelihood of outer retinal reconstruction was very, very unlikely. Mm-hmm. But from 600 to 800, it was likely you could get some form of reconstitution. In some cases, complete reconstitution, as was shown, and in some others, just a partial reconstitution. But whether it was, in fact, the person who had the best visual recovery was someone who had a partial reconstitution. So I guess there are other factors that may be also involved.
This is one more field where we never mention microperimetry, but I think it's useful. Since I'm doing that, I have learned so much, because sometimes we talk about visual acuity improvement, but we don't know where and with which sensitivity. So we should do it more routinely, I think.
The whole idea is that those eyes in which you do not seem to expect outer retinal reconstruction, they should be candidates for another type of surgery, and probably not flap surgeries.
Right.
Okay, thank you, Ogugua.